All right, so this is the last section. Any questions before I get started? All right, so we're going to finish up our Peds stuff, moving into geriatrics, and we'll do a little bit on just some final stuff on prescription writing at the end there. Anyway, we're talking about drug administration for children. We mentioned with IV administration, getting IV access can be pretty tough in a lot of cases because, again, how do kids' veins compare to adult veins? They're a lot smaller, right? So again, they're going to be harder to find. Sometimes we can have things that can kind of help us out. So there's something called like a WE site that actually shows like an infrared light onto the patient's skin, and that will actually make the veins a little bit more easily visible. Things like that can kind of help us out. But other things that can be useful to consider are things like, well, how much volume can you give to a patient, especially when you're dealing with pediatric patients? They're smaller, so you don't want to give as much volume for things. And so how do you use less volume of drugs? What do you do to that drug? Well, you don't change the dose necessarily, but what do you increase? The concentration, right? So use a bigger concentration, so that way you're using less volume in order to get the same dose into the kit, essentially, right? So that's the important thing to consider there. So we generally try to go for more concentrated varieties to try to limit the volume we're giving some of these patients. Because when you're getting a ton of medications, you can start to get close to like fluid bolus levels of volume for these kids, and they may not be able to handle that much volume in some cases. So you have to be careful with that. But the more concentrated a drug is, in some cases you may find them more likely to cause thrombophlebitis. They can cause extravasation potentially and lead to tissue damage. So you have to be really careful when administering these drugs. And what's a good way that I can, where specifically in the veins can I administer the drug that kind of helps to mitigate that concentrating effect? It's a hard way to ask that question. So there's like peripheral access, but then what's the other means of access? It's central, and where does that dump out the drug into? Well, it goes basically to the vena cava, right? So again, typically that central access is going to go over to the vena cava. So that way, when it gets dumped out, there's a ton of blood coming back in from the venous side. So that helps to dilute it out pretty significantly right there. And so we can get away with higher concentrations, usually with using central administration. However, that's more intensive. It takes more time to get that set up. Not as easy as getting like a peripheral stick. So that's something to consider there. And we have to time things out to make sure, okay, well, they have to get multiple drugs at the same time, but how do we adjust the frequency and things like that to try to make it easier on the nursing? Because in some cases, if you only have one peripheral IV, like only one drug may be going in at a time, versus if you have like a triple lumen central access, that may be a lot easier. And so you have everything kind of running the gamut in between, to where a lot of times we get calls from nurses saying like, hey, I got this drug and this drug and this drug, and they have total parenteral nutrition going in one line. Like, how do I administer all this stuff? What are the compatibilities? And so there's things like that we have to kind of work through to make sure that we don't have like drugs precipitating on the line and all kinds of other issues. So and then the other big thing is therapeutic drug monitoring. What drugs do we do that on? Remember any examples? Vanco's one. Yeah, Vanco's a big one. Yeah, they're aminoglycosides are the other big group, but like certainly a lot of anti-epileptics, things like that. But the Vanco and the aminoglycosides are the big ones we do most commonly on the inpatient side. But again, what do you have to draw to get those drug levels? You have to draw blood, right? And so for like, pediatrics, they try to have smaller containers, but you still have to draw blood, right? And we can actually find pretty, apparent drops in hemoglobin in hematocrit for these patients because we are pulling off so much blood in some cases. So you try to make sure that labs are being done at the same time, so that way you can run them off the same sample potentially, things like that. Considerations you have to think about when you're dealing with these small kids, especially like neonates. They can have pretty big drops in their hematocrit and hemoglobin due to you just drawing off too much blood for different labs. Other things you want to make sure whenever dealing with pediatrics is you never just want to like hang a bag and just let it run, right? The pediatrics, you have to be very specific about the volume they're getting, about the dose that they're getting, and so we have things like pumps that are designed to administer very exact volumes, very exact rates and doses for these patients here. So for instance, here's kind of an old school kind of example here, but you'd have like say like a mixing chamber where drugs actually going, and then this would be able to go into an actual pump, which has usually either it will have like a sort of a cam sort of system that will pull fluid through the line, or in some cases I'll show you an example of a syringe pump, which actually has a device that actually will push the syringe, the stopper into the barrel, and that will give a very kind of exact amount of drug over time. Then it obviously goes into the patient. And so it's really important that these systems are designed to protect the patient. And so we have drug libraries that are set up. So that way you can actually have very specific, ceftriaxone, we're only going to do this concentration at this hospital, and we're only going to be able to give it, via this big of a dose. And so there's a lot of hard limits that are set in here. Make sure you're not giving too much, you're not giving too little, you're not giving it too fast, too slow, and you're not using a wrong concentration, right? And so in this case, you'd put the drug syringe into here, and then basically this can determine how big the actual syringe is. So that way a 60 ml syringe obviously has a lot bigger diameter than like a 3 ml syringe, and this can detect that. And then this will push in this direction in order to get the drug flowing through the line. And so it's really important we're using accurate libraries, so that way you don't have any issues to where a patient is getting a wrong concentration, wrong dose. We've had some errors in some cases where we have a patient being transferred in from a different hospital, and so they were getting IV medication via this other hospital's concentrations and their standards, and then switch over to us. And if we didn't take that into account, that we have different practices, you can end up getting over or under dosing and things like that for your patients. You have to be really careful with this. Oftentimes the nursing is dealing a lot with this, but you'll have some influence on this because you're choosing what concentration they get, you're choosing what dose they're getting, how fast to give it. Those are going to be things that are components of your orders when you write for this stuff inpatient. Okay, how do we normally measure out doses for these kids, for oral doses? Good, yeah, we want to make sure we're using mLs when we're doing this. What's the easiest way to measure that? Yeah, use a dosing syringe, right? So I remember we were having to give my kid Benadryl a couple weeks ago for some allergy symptoms, and basically they had a little cup that came with it, right? And so you can pour it into the cup. But I went ahead and put it up to the 5 ml mark, and when I drew it up with the actual dosing syringe, it was like 6.5 mLs, right? So again, those cups are not going to be super accurate, and you can end up having issues where you're having either under or overdosing. Dosing syringes are the #1 most accurate way to do this, and you've already gotten some experience of that when you're writing your Peds prescriptions this semester, right? So okay, well I can write to like the 10th of an ml. Usually you can get that accurate. Much more than that, you can't really do that, at least for typical outpatient sort of use. But it's very important we're not doing things like teaspoons, tablespoons, because again, how much is a teaspoon? It's 5 mLs, yeah, and then tablespoons usually 15 ml. But again, it's going to depend on where you're getting it from. So if I go to IKEA and I get their Swedish spoons, perhaps they have a different size teaspoon than if I go and get it from Walmart, right? So again, you can find some differences there, and you want to make sure we're being accurate, especially when dealing with peds. A lot of times you're going to find the kids do not like medications, and I have so much respect for peds nurses for getting these kids to actually take their drugs, because until you've tried to give a kid an oral medication, they spit it back out at you, you don't know just how frustrating of an exercise it can be. That's why we like suppositories so much, because they can't really fight against that. Just put it right in there and they're done, right? I know, so even my kid's like 6, I'm like, you want a suppository? But you have to consider the sensory appeal. That taste is really important. Texture can be really important here. I know nowadays a lot of medications taste way better than they used to. I remember when I took medications growing up, like they were awful and they never wanted to do it. Now like ibuprofen's orange flavored, and you get grape flavored Tylenol. I'm trying to make it a little bit more appealing, but kids usually know when it's medicine they're getting, and they'll still try to fight you. So consider that. Look at things like drug food interactions. So again, kids were oftentimes giving them a lot of what sort of drink. A lot of milk, right? And we know that milk binds up with a lot of different medications like fluoroquinolones and other things like that. So you got to be careful with drug-food interactions. It's something you want to keep in mind. And then also look at a lot of inactive ingredients. Very frequently when kids have a reaction to a medication, usually it's not going to be necessarily the drug they're having a reaction to. It's one of the kind of inactive ingredients mixed with it. So like dyes are really a big causative agent here. So if you ever see someone with like a red dye allergy or yellow dye allergy, usually it's going to be linked back to they were exposed to a drug product and they were able to identify it was a specific dye. So in some cases you may need to find like dye-free products. So if we have some kids who have to get dye-free Tylenol because they're going to have a potential allergic reaction to anything that has a dye in it. So those are things to always keep in mind when dealing with these kids.
Is that available like over the counter, or is that something they have to get a prescription for?
No, that's usually it depends on just where you can find it, where you have to order it from. So you may if you go look at the Walgreens, it may not have any on the shelf, but you could have them special order for it. It's still over the counter. It's just a different formulation of it without the dye. Yeah, so that can be kind of tough. But do you guys remember when we were talking about seizures at all? I mentioned a ketogenic diet. Do you remember what that was? What is that? Like no carbs, right? So again, you're trying to get the patient into a state of ketosis because that does what to your pH? Yeah, it makes you more acidic, and that actually increases your seizure threshold, so it makes it more difficult to have a seizure. And so we have these kids who will come in and they'll actually have like a dextrose allergy will be listed there, and that tries to give us a clue that, hey, this is a ketogenic diet patient, because in a lot of these oral suspensions and syrups and things like that, what's a big component there? There's a lot of sugar, right? There's a lot of sugar in them, and so we have to make sure we're adjusting dosage forms to make sure they don't get that extra carbohydrates, because you have to count every single carb that kid's getting in a day to make sure you keep them in ketosis. And so we'll do things like have to take tablets, crush them up, and then dissolve them in water. It's not super appealing for the child, but again, if it keeps them from seizing, then that's going to be therapeutically beneficial for them. So again, just considering active ingredients. If you deal with kids often, you'll probably end up running across one of these kids that have kind of these special needs associated with them. Okay, so make sure when you're prescribing meds, make sure you get the most up-to-date weight available. If you ask me what my kids' weights are right now, I can probably give you a rough estimate, but I don't weigh them daily, so I don't know what they are day to day, right? I know I have a little monster baby, and I know my toddler is probably close to 30 pounds, but who knows? So a lot of times parents may only have like whatever weight they got at the last time they were at a doctor's appointment, which could have been months ago, right? And kids are rapidly changing weights. So make sure you get a most up-to-date weight as possible. Make sure you're checking with available references, right? So Lexicomp's great, Micromedics is great, Hippocrates is okay, but depending on where you're working at, and again, I don't know what Florida Hospital uses as their drug reference of choice, but wherever you're working at, you're going to find that find what the reference is and kind of get familiar with it. If you're dealing with infectious disease stuff, there's a red book that's great for peds infectious disease. Look that stuff up. And then make sure you're using those right references. There's one called Neofax used like in the NICU all the time, so you'll get familiar with that if you work with these kids. And then consider when you're counseling patients, like how do you communicate to them? Obviously, if they're like 2, may not be a whole lot of communication going on there where they can kind of understand what's happening. However, if it's like a teenager, like you kind of want to empower them to be kind of custodians of their own healthcare, and you can say, okay, well, here's what we're doing. You don't have to explain to the parents necessarily; they should hear it too. But you need to make sure you're kind of tailoring it to dealing with that particular age patient. Okay, so let's do a few drug dosing calculations. I know you guys are experts already, but just make sure you're familiar with what is going to be on the exam. The exam, you won't need a calculator. You can do it all just with scratch paper, but you will have some math on there, okay? It should be easy questions, right? It should be easy points for you guys. So let's say, for instance, we have a 15-kilo kid who's getting amoxicillin for an acute otitis media, and this is more difficult than what will actually be on the test. Like the stuff on the test, it'll be easy round numbers essentially. The amoxicillin comes as a suspension, 400 mg per 5 mLs. How much did the kid get? Okay, so what's kind of your first step when you're doing this? 15 times 90. Good. So you know that their total daily dose at this point is going to be 15 times 90. I think I have it on the next slide. Yeah, so it's going to be 1350 milligrams you're getting per day, and then you're going to do what at that point? Divide by 2, right? So again, when it says divided BID, so you know they're going to be getting it twice a day, divide that up, so then they're getting 675 per dose, and then what do you do? Yeah, so I always hate the nomenclature here. I hate how they still put, per 5 ml concentrations on things. Like it'd be easier if everything was just per ml. But that is again going back to that old mantra of using, or the old paradigm of using, teaspoons and tablespoons and things like that. So that's where that comes from. But 400 divided by 5 is, anyone know? It's 80. Yeah, it's 80 milligrams per ml. So basically, I would just take that 675 divided by 80, and I should get my answer at that point. You get 8.4 mLs per dose. Perfect. Right. So again, very simple, very straightforward. You guys have a lot more experience with this now. So again, when you go on rotations, you should be able to kind of pull this information back out whenever you need to. We do the same things when we're doing drug dosing calculations for IV medications. Because again, when you imagine, we dealt with this a lot, like in the ER setting, like a patient comes in, they're coding, right? Like you have to give medications very quickly, and so it's fine to know what the dose is. I'm going to give this patient, 0.01 milligrams of epinephrine per kilogram. The nurse doesn't care. They want to know how much volume they're actually going to be administering to that patient, right? They need to know I'm giving 0.3 mLs, or I'm giving 0.6 mLs, and so you have to be able to do that pretty quickly. It's good if you have references available, but you need to be able to figure out this math pretty quick in those cases. Obviously, if you can take your time, it's going to be a little better. Yes, sir.
Is there a difference when you're prescribing antibiotics to children if you put it BID for twice a day versus every 12 hours?
Not in the practical sense. So if I were to write down an outpatient prescription, Q12 versus BID, the patient's probably going to get the same drug at the same roughly the same time, right? So they'll probably get it in the morning time. They'll probably get it before bed, right? In the hospital, that takes on a different meaning. So usually what you'll find at most hospitals is they have standard drug administration times. And so if you write, say, BID, it'll probably be like at 8 and 8, right? Because again, you probably don't want to do stuff at 7 o'clock, 7A or 7P, because what happens then? Anyone know? In a hospital, that's when shift change happens, right? So you don't want to do anything during shift change because that's when nurses are giving report outs and things like that. So they get really cranky with you when you schedule stuff at 7 o'clock, right? So anyway, so usually 8 and 8, right? Or like our hospital, we just moved to 9 and 9 for whatever reason. It's better for nursing. And so that would be, you know, BID. TID might be like, you know, 8, 8, 12, and 8 or something like that. You know, so this is standard times. But when you write Q24 or Q12, it'll be very specific to that hour. So if I write for Q12 hours and I write and the order starts at 6 p.m., it'll be 6 p.m. to 6 a.m., right? If I write TID, it'll be, you know, 6 p.m., I don't know, maybe 2 a.m., and then whatever it is that happens to work out. So that will make some difference in the hospital side of things. And so oftentimes we'll have patients where they're writing for it to get, you know, Q8 hours, and really it's not a medication that's super time critical, and they could have gotten just TID, and that way they'll only get it during kind of waking hours. And so it can be kind of a patient interaction or a patient kind of detriment if they're having to be woken up to give medications. So it depends on a lot of different situations. But for things like antibiotics, typically we like Q8 hours in the hospital, so that way we know that yes, they're getting these very specifically every 8 hours, so we know that their drug levels are going to be sufficient to kill off that bacteria. But in the outpatient world, you know, Q12 hours, BID is the same thing roughly. You know. Anyway, all right. So say we have. I don't think I did the math on this slide, so I'll go ahead and do the math with you guys. All right. So let's see. I can get my calculator out. I'm not checking Twitter or anything. Okay. So we have an 18-kilo patient with GERD symptoms. We want to give them Zantac here. So we're going to do 4 mg per kilo per day, divided twice a day, and ranitidine syrup is 15 milligrams per ml. So how much should the patient receive per dose? So first step is 18 times 4, good, and that is 72, and divided by 2, very straightforward, yep, 36, and then divided by 15, and we get 2.4. So the patient gets 2.4 mLs twice a day, very straightforward, perfect. Okay, so again, this one always gets some people tripped up, and again, this is important because what's on your prescription assignment? You might have Bactrim on there, right? Perfect. Okay, so let's say we have a 12-kilo patient. They're getting Bactrim for cellulitis. They get 4 milligrams of trimethoprim per kilo per dose, BID. Suspension is sulfamethoxyl 200 milligrams and trimethoprim 40 per 5. How much should the child receive per dose? So what's my first step here? So I'm going to do 12 times 4, and then that gets 48, and then what? Do I need to divide it by 2? I don't in this case. Right, so when I say 4 milligrams per kilo per dose, you don't have to divide by 2, right? They're still getting it twice a day, but you don't have to divide by 2. I see errors with this all the time where people are looking at the drug reference and they don't notice that difference between per dose versus per day, and that makes all the difference. You can end up giving a double or giving only half the dose what this patient actually needs if you were to divide by 2 at this point, right? So you don't want to do that. So they're getting 48 milligrams of trimethoprim per dose twice a day. Okay, so at this point, what do I do? Yeah, so yes. So again, here you see we're dosing off the trimethoprim content, so we don't even care what the sulfamethoxazole is at this point because it's a fixed concentration. That doesn't really change. And again, of course, the last day the helicopter decides he wants to start taking off again. You guys can hear me okay, or do you want me to stop? Yeah, okay. So anyway, so we're going to take that 40 divided by 5, which is 8, and then we're going to take our, whatever our thing was, 48 divided by 8, and it's going to be 6 mL. So basically that kid's getting 6 mLs twice a day. Make sense? So you can be very careful when you're looking at these questions. Make sure you notice, is it per day, is it per dose, to know whether or not you need to divide it up. So for instance, if I did have a patient that was getting something that was, say, 10 milligrams per kilogram per day given daily, that's another situation you don't need to divide, right? Because again, they're only getting 1 time a day regardless. Good. Okay, so let's say we have a 20-kilo child who's been receiving 2 teaspoons of acetaminophen 4 times a day for fever. Mom's reporting this to you. The usual dose we would normally give is, say, 15 mg per kilo per dose. And here's the suspension. The concentration here is 160 per 5. Is that child being dosed appropriately? Okay, so let's figure out what a normal dose should be for that patient. So how do we figure that out? Yep, so we're going to do 20 times 15, which is? The 300, so the patient should be getting 300 milligrams of acetaminophen per dose, okay? And so then what do we do at this point? So 160 divided by 5 is? 32, yeah, whoever came up with the 32 milligram per ml solution, I have no idea. I only know that because I work with Peds every day, and so like, or, you know, 1 day a week now. But so I just know that inherently, but again, it's a very goofy concentration. But I'll take that 300. Oops. There's a clear sign on this side. So I'll do 300 divided by 32. Yeah, so you get 9.4 roughly, right? And so again, the patient has been getting how much? 10 mLs per dose. So is that close enough? Yeah, it's close enough, right? You know, it's within a 10% change, right? So again, that would be appropriate for that patient. We can say, hey, mom, you're giving the right dose. Because a lot of times we'll have patients that will come in, you know, for fever, things like that, and we'll say, well, okay, well, what'd you give for the kid before he came in? So we give Tylenol. You always want to ask, well, how much were you giving? Because again, they may have been given a smaller dose. You know, it's funny because even my wife made that mistake the other day because we were trying to give some Tylenol to my toddler, and I was like, oh, well, how much are you giving? She's like, oh, I just drew it 5 mLs. And I was like, okay, well, let's actually do the math there, and actually ran through it. And I was like, oh, it actually needs like 7.5. You know, so it's more than 10% difference. So that would have been, you know, clinically significant. So it's one of those things. Not to denigrate my wife at all. She was dealing with a cranky toddler and was like, I don't just get something into her at this point. But you know, you can see how it can go either way, right? So you can see how it can under or overdose kids in those situations. Next thing is going to be the fluid boluses. So again, you can look like a rock star in rotations when you go out there and you know that 4-2-1 rule like a champ, right? So again, if you know that, you're going to look very, very impressive because a lot of people, even seasoned practitioners who don't deal with peds, don't know how to do this, right? Okay, so typical fluid bolus for most patients is going to be 20 mLs per kilo. Where does that usually cap out at? At least for kids, we don't go above a liter, right? For an adult patient, you may do 1 to 2 liters, something like that. But typically, you can't go wrong with capping out at a liter, right? I can always give more fluids. I can't necessarily take it back, right? Unless you hook up a dialysis machine or give them Lasix or something. So you can always give more. So typical fluid bolus is 20 ml per kilo. And then for the maintenance rate, right, because you're going to give them a bolus, and then typically they'll get put on a maintenance rate. Do the 4-2-1 rule. We've covered this before, correct? Yep. So the first 10 kilos they get 4 mLs per kilo per hour. For the second 10, they get 2 mLs per kilo per hour, and then for every subsequent kilogram, 1 ml per kilo per hour. All right, so if I have an 8 kilogram infant, how much are they going to be getting? Yeah, so 32 mLs an hour. What's their fluid bolus? 160 mLs, right? Yeah, so again, like an 8 kilo infant, like that's you know, if you accidentally hung a liter of saline or let that run in, I mean, that's, you know, it's 5 times what their actual fluid bolus should be. Like and mistakes like that have happened. That's why you know, pumps are so very useful in making sure we're going to give the right dose to that patient, right? How about a 1,200 gram neonate? How would you figure that out? Convert. So 1,200 grams is 1.2 kilograms, right? So you always want to keep your units straight. So 1.2 times 20 would be? Yeah, so 24 mLs. Yeah, so again, not a ton. This is you know, it's not uncommon we would have NICU kiddos this small, right? You know, again, born premature, they can definitely come out very, very tiny, from little peanuts when they come out that small. And then what would their fluid maintenance rate be? Yeah, 4.8 mLs an hour, right? And again, the smaller they are like that, like you want to be careful fudging the number. So like you could say 5, but it might be too much for that kid, right? So be careful with that. How about a 45 kilogram adolescent? How much would their fluid bolus be? Yeah, they get 900 mLs as a fluid bolus. You know, some people might just round to a liter, but you know, it depends on the practitioner. And then what would their maintenance rate be? The first 10 they get how much? 40 mLs an hour. For the next 10 they get 20 mLs an hour, right? So now we're at 60, and then how much extra? 25. So 60 plus 25 is going to be 85 mLs, right? Again, if you just practice with this, like, you know, we get fluid orders all day long at the wards, like you just know it. Like you just look at it and say, okay, this is roughly the right amount. How about a 100 kilogram teenager? How much would I give them as a fluid bolus? Yeah, I'd probably just cap it out at 1 liter. That would be appropriate for this patient. Again, I can always give another liter if I need to. And then their fluid maintenance rate would be? Yeah, 140 mLs an hour, right? So again, you're going to get 40 for the first 10, you get 20 for the next 10, and then he has an additional 80 kilograms you have to factor in. So again, 60 plus 80, 140. So 140 mLs an hour would be an appropriate maintenance rate for that patient, right? And that's not uncommon. We'd have like, we have the World of Sports over at Disney. We get a lot of those kids transferred over to us when they have like football tournaments and things like that. They get injured, they come over to us, and so you can have these big beefy 17-year-olds that are coming in for us, and they need fluids, right? They're dehydrated because they've been out in the sun, running around all day. So there's things to consider. Okay. There's another one that comes up in the ER quite frequently. So let's say we have a 24 kilo patient who's getting lidocaine 1% solution. They're getting intradermally because they had a laceration to the face. The max they can get is a 5 milligram per kilo dose. So how many mLs can this patient get? Do you remember the rule when we have percentages as a concentration? Move the decimal place over one spot. So if I needed to convert that 1% over into milligrams per ml, move it over one spot. So 1% lidocaine would be 10 milligrams per ml, right? So you can move it over to the right. If it had 2% lidocaine, 20 milligrams per ml, right? So again, this is a very handy thing that works for anything expressed as concentration, right? Or expressed as a percentage there. So if I know my dose is 5 milligrams per kilogram as a max, how do I figure out what the max they can get is? 24 times 5, and they get what? 120 mLs, or I'm sorry, 120 milligrams is the max that they can get. And so then how many mLs can they get? Divided by concentrations divided by 10. And so they can get a total 12 mLs, right? So if they have really exceptionally large laceration, they can get 12 mLs potential. Or you could use a higher concentration, maybe only give 6 mLs if you use the 2%. So keep that in mind. These type of questions will come up on the exam. Again, the math will be able to be done in your head pretty easily. So just, scratch paper will be enough to do most of this, right? Okay, so any questions on that? So let's start covering our geriatric stuff. So again, we've covered a lot of this before, but it's good to kind of like bring it all together towards the end. Now you have a little bit more context for medications and things like that. But we do know we have an aging population, getting older all the time, and so typically geriatric we consider to be when they're greater than 65 or so. However, it's not uncommon you have these patients who are 80, 90, 100 years old in some cases. And sometimes you'll even have 50-year-old patients who are, had the organ function of someone who is much older. So it kind of runs the gamut there when you're dealing with these patients. But we're going to look specifically at kind of like assessing function, assessing the things about the history you want to find out from a drug perspective, and then looking at some of the changes we're going to see that happens in these patients. So doing really comprehensive assessments for your geri patients are going to be really important because you want to figure out like kind of what their functional level is going to be. Can they take medications on their own? Are they able to take medications via the route that you're specifying for them? Different things like that we're going to try to figure out. A lot of times there's going to be an interdisciplinary team that are helping to care for these patients. So for instance, having nutrition involved, having pharmacy involved, having PT/OT involved with you guys, the practitioners, to make sure that kind of all aspects of the patient have been assessed and have been considered, right? Because again, not any one person can know everything. Some people like to think so, but in general, it's good when you have more heads working on a problem, especially when they have different kind of specialties. So again, looking at their activities of daily living, kind of seeing like what they're able to do for themselves. Can they get dressed? Can they cook for themselves? What can they do essentially? And that can be helpful because again, if they're not even really able to get out of bed in the morning, like what's the likelihood they're going to be able to be adherent to a good medication regimen? Unlikely. And what's the rule typically with older patients and how many meds they're on? The more typically, right? So you always think more is better, not in these cases, but these patients will be on 10, 15, 20 medications potentially, depending on what their, litany of comorbidities are going to be, right? So someone who has COPD, hypertension, hyperlipidemia, diabetes, like that's not a uncommon combination of disease states, but you can see how many medications can start to build up on that, right? Just based off what we've covered already for those different disease states. But looking at the nutrition aspects of things, so we want to make sure that one, they can actually swallow pills, they can swallow the tablets that we're actually prescribing for them. If they couldn't swallow tablets due to things like dysarthria, dysphagia, things like that, what could we do for them instead? Give liquid, yeah. So you can kind of think about these really old patients as almost like reverting back to like smaller kids, right? So in some cases they're incontinent, in some cases they can't really take things via tablets because of poor dentition, things like that. So switching back to going to liquids again can be important. However, we mentioned a lot of liquids contain what? a lot of sugar, right? And again, some of these patients are diabetic, right? These are things you have to consider. They could have depressed appetite, and so certainly if they're malnourished, we can find that can have an effect on things like, drug metabolism. That can affect distribution of things, if they're muscle wasting, if they're having a particularly high amount of adipose tissue, that can affect volume distribution pretty significantly, as we'll see here in a minute. But other things are going to be like, what kind of food-drug interactions do we need to worry about? What are they consuming a lot of? Are they getting a lot of milk? Are they only drinking coffee? Like, what are these different things to figure out about your patient? To try to get an idea of like, okay, well, there are drug interactions going on here, drug-food interactions. Are they even eating enough to really, make sure they're nourishing themselves? These are all things you're going to be finding out about. So again, ask them, kind of a detailed recollection of what they were eating in the past 24 hours. Typically, these patients like a lot of routine, right? So again, typically they'll probably eat pretty similar things from day to day. And we did this very frequently, like especially when I was on rotations and got to manage an anticoag clinic, right? Because when I was doing a lot of warfarin counseling and warfarin dosing, what was one of the big things I asked about from a diet standpoint? Yeah, so okay, well, and this was in Putnam County, so these are a lot of people that are like growing their own vegetables and things like that, pretty rural community. And so I was like, okay, like how much kale are you eating? How much spinach are you eating? How much, different things, collard greens, all of that, because that was like food that was like staples for their diet, and we had to adjust around that, right? So you don't want them to stop eating that completely because that's good, healthy food for them. However, you need to make sure you're adjusting the warfarin to account for that and make sure that they're being consistent, right? So if you don't want to go from eating all spinach salads all 1 week and then go to the next week and eat nothing, right? So these are things we would kind of take into account. But vitamins, supplements, if they're taking anything over the counter, these are questions you want to ask to get an idea of what could be potential interacting factors here. Other things like asking how many meals are they eating a day? Are they getting enough fiber in their diet, because that can lead to worsen things like constipation for these patients, which can be a problem, especially like chronic pain patients are often on what? Opioids, and opioids do what to the GI tract? Slow it down, right? Calcium channel blockers, slow down the GI tract. All these different things can impact that, and so those are other things you have to consider there. Ask about alcohol, right? That can definitely be interacting with patients who have like chronic liver disease or certain medications. We mentioned warfarin, but if they're, what does alcohol do to your ability to clot? Typically inhibits it, right? It's going to be more of a blood thinner more than anything else. So again, you can see that can be an issue where they're having excessive bleeding and bruising. Okay, how much alcohol are you having? Is that going to be playing a role here? Right, so the big things to kind of consider: look at weight over time, make sure they're not adding on a bunch of weight or losing a bunch of weight. You want them to kind of stay steady for the most part. Ask like, okay, well, who's doing the shopping for you? Can you do it yourself, or are you having someone help you? Who's helping to cook for you? Things like that. Are there programs available like Meals on Wheels that can help you make sure that they're getting good nutrition? Things like that. Okay, from a laboratory standpoint, it's important to consider lots of things. So for instance, off of a complete metabolic panel, what would you find on a complete metabolic panel? Liver function will be on there, so that's a good thing to assess for, to see if we're metabolizing drugs appropriately. What else? Glucose, again, it's good for our diabetic patients or someone who has altered mental status. So you definitely want to check the glucose. That could be a sign of hypoglycemia. Kidney function will be on there, as evidenced by what? BUN and creatinine, good. Carbon dioxide is going to be on there. Bicarb will be on the basic metabolic panel section. Mm-hmm. Electrolyte, absolutely. Sodium, potassium, and again, another thing you're looking for with older patients with presenting with nuanced altered mental status, what's their sodium? Hyponatremia is something that gets overlooked in some cases, and that could be a very common thing that can cause that. Good, those are the main things you're going to be thinking about. How about, things like A1C, what's that going to tell us? Yeah, average blood sugar. That's going to be important for your diabetic patients. We can look at things like, the CBC can help us. Is there a sign for infection going on there? Are they, platelet counts looking good? Different things like that. So again, you're going to be looking at all these different lab values. And again, you want to know what their baseline is and look at trends over time. Because a lot of times, like a lot of patients who show up to like the ER and, they come in, they say their creatinine's 1.4. Okay, so that's not great, but is that new for the patient? Is that old for them? You know, is it something that they're steadily at 1.4, or they used to be at 0.8 and now they're at 1.4? Those all have very different implications for how you're going to manage that patient. And so having a baseline set of data can be very useful. So it's nice that they all go to the same place all the time, but if you're traveling and you go somewhere outside of that typical network, if you go to, you know, or that's the first time you've ever seen that patient because maybe they had no medical care before, that can be a bit of an issue there, because I don't know if it's something new or something that old that we're just now discovering. So we mentioned typically polypharmacy is more the rule than the exception for the majority of these patients. Typically, you're going to find more and more meds being added on because these patients are living for longer, they're developing more chronic diseases. You know, like for instance, like we talk about HIV patients. You know, before, like they used to have a very short lifespan for the most part, especially back in the 80s. Nowadays, we have very good heart therapy. Now they're living for a lot longer, and they're developing a lot of these chronic conditions they weren't developing before: diabetes, hyperlipidemia, and again, a lot of their medications are not being very helpful from that regard. So these are things you're going to be looking at. Also looking at evidence-based guidelines, you know, how many medications should they be on? Is that appropriate for the patient? So imagine someone who has, you know, a past MI, what medication should they be on? So they probably need to be on some sort of anticoagulation, most likely. What else? Beta blocker you mentioned. ACE inhibitor, probably, right? Help with that left ventricular remodeling. What else? Yeah, nitroglycerin. Yep, so probably a statin, right? So probably on statins. So already at 5 medications. That's only for one disease state, right? Imagine we had, and again, some of them pulling double duty, but imagine now he has diabetes, and now let's say we are putting on metformin, and maybe he's on Victoza, and now he has COPD, and now he's on albuterol rescue inhalers, and you know, Ceravent controller. So again, the list can spiral out of control there. But you know, based on the guidelines, they have certain recommendations that, well, we think this is best for our patients, and so the list gets longer and longer. Anyone ever heard of like a brown bag event? What that is? Yeah, so, and we would do this when I was in pharmacy school. We basically would go to these nursing homes, and we would have, like, you know, an older, maybe like a 3rd or 4th year pharmacy student along with us. You know, this is like my 1st or 2nd year, and we go to these nursing homes, and they say, all right, just bring out your medications. And let me tell you what. For one, there's some nasty medications that are out there. They're not very clean. However, they'd be bringing out stuff from like the 80s. They'd be bringing out stuff they hadn't been on in like 2 years. And because again, usually like in these older patients are on a fixed income, they don't want to. They like to save things, right? They don't want to. They don't want to be wasteful. And so they have medications they haven't been on in years, but they're still around. And again, if they have, you know, kind of you know, poor memory, things like that, they may start taking medications they shouldn't be. Potentially, they'll have drugs that are expired. They're going to have multiples of the same pill bottle. Even so, again, it can be very confusing. And our goal is to try to get in there and be like, okay, well, do you still need all of these? Like, what stuff can we throw away? What stuff can we get rid of? And so it can be very useful, sort of you know, helpful thing for them. And again, do you think it all came from one prescriber? Often no, because if they're seeing their cardiologist, their PCP, they're seeing their endocrinologist, they're seeing the rheumatologist, you know, so different people don't necessarily review that that medication list, and that's where you guys are really well poised from being, you know, mainly focused like on a more of a family practice sort of setting. You can be that central person. You can be that person that kind of looks at their entire med list and be like, well, maybe you don't need this, this, and this, or maybe this is actually treating a side effect from this medication. Maybe we don't need both of those. Because again, most times people, are they hesitant or pretty willing to DC medications other people wrote for? Very hesitant. Most people do want to touch someone else's medications because you don't want to get in trouble with that provider, right? You don't want to step on anyone's toes. However, sometimes you need to be that person to be like, hold on, we got to stop what we're doing here. This is madness. Stop this medication, and go here. You can communicate with them and try to get a better plan, because a lot of times they're working off partial information as well. You know, if the patient's not really given the full story, saying, oh yeah, well, I'm also seeing like these 3 other doctors, you're not going to have the full history there, right? And again, us from a pharmacy standpoint, we might not get the full picture either, because you think, okay, well, they go to CVS for all their medications, but is that always the case? No, because they'll go to, say, Publix, so I can get this one for $4, and I can go to Walmart because I get this one for free, and we don't all communicate with one another. Certainly, all CVSs communicate, all Walgreens communicate, but you know, Walmart to Publix to CVS, nothing, right? So that can be very difficult if we don't know what the full medication list for those patients is. We can't look for interactions if we don't have the information. So. Anyway, you know, typically, you know, again, you're going to just see typically an 8% increase in the number of medications that patients on per comorbidity. So it's not uncommon to have patients who are on 10, 15 meds in some cases there. And typically when they get hospitalized, they're probably going to be leaving on more medications than what they actually came in on in a lot of cases. So that's another big reason why if we can keep them in the hospital, we can keep them from getting more meds on board typically. That's going to be a useful thing. So usually you're going to find more adverse drug reactions occurring here with the more medications you add on board. So, and a lot of times you're actually treating adverse drug reactions with other medications, which can lead to their own adverse drug reactions, which you have to treat with other medications. You can see how it can kind of spiral out of control there. Falls can be a really big deal here with these patients because a lot of these things, like a lot of CNS active meds, can cause sedation. They can cause postural hypotension. They can cause decreased muscle stability. So when they get up in the middle of the night, imagine you put them on a diuretic. They get up in the middle of the night because they have to go to the bathroom. What can happen? They fall, and then they break a hip, right? And we see huge increases in morbidity and mortality after a fracture like that. A lot of patients cannot come back from something like that, especially the older ones, and that can be huge. So a big decrease in quality of life for those patients. That can be a big deal. Decreased compliance, either due to their mental faculties waning, or just some of the what I call intelligent non-compliance. Anyone know what that means? They choose not to follow your instructions, right? So, for instance, they have a hard time, maybe a financial hardship, getting the medication, and you tell them to take it twice a day. Or like, well, maybe I can just get away with taking it once a day. And they come back and see you, and you say, well, you're taking your medications like I told you to, and they say, of course I am. Yeah, of course, because they don't want you to chastise them, right? A lot of patients, there's a sense of shame associated with that, and they're going to tell you whatever you want to hear in a lot of cases. And so you may be like, well, your blood pressure is not really under control, but you say you're taking your stuff like you're supposed to. You say you're compliant. I'm going to go ahead and increase the dose. That may not be most appropriate for them. Maybe they weren't even taking it right to begin with, right? So these are things you have to kind of think about. It's not that they want to lie to you and they're trying to be, for any nefarious purpose. It's just that's human nature in a lot of cases. So other reasons for decreased compliance, having multiple medications, having very complex dosing schedules. So I mentioned like HIV treatment used to be taking, a ton of different pills, dozens of pills a day, 4 or 5 different times a day. Now, if we can get it to more simple regimens where they're taking something once a day, twice a day, they can take everything at the same time. That can be much more beneficial for the patient from that standpoint. I remember I had this one lady who came up to the pharmacy when I was a student, and she had very poor eyesight, right? So again, you have to think about the physical disabilities associated with this. She was actually like mentally completely with it, but her eyesight was just terrible. And so she had this system where she was on 10 different meds. She knew all of her pill bottles based on these symbols that she would write on the top of them. So she knew that the red triangle was metformin, and she knew that the purple circle was going to be metoprolol. Right, and I was like, there's no way you know all these just by the symbol. And she was like, no, quiz me, and I quizzed her, and she knew every single one of them. So you don't always get that lucky to have that sort of mental. I don't even know I could do that. So not everyone's gonna have that same kind of mental acuity to be able to do that. However, these are things you have to consider. Other things, how do most pill bottles typically come from the pharmacy? Like what's on top of them?
Logo.
Well, logo and stuff, but typically the containers are meant to be child resistant, right? So again, it's one of those things where I know more kids that can get into those things much more easily than geriatric patients can. And considering if they have rheumatoid arthritis or osteoarthritis, that can be very difficult for them to actually open up. So that can be a reason for decreased compliance. Making sure that you're putting on actual simple screw top caps versus the ones that are going to be more locking. Anyone ever gotten something from like Walgreens, then you can actually flip them over? Yeah. So you can flip it over and just do the screw top versus if you flip it over, it'll be like the locking child resistant ones, right? And again, I don't say child proof because nothing is really child proof. It's all a matter of time and curiosity for the kid before they get into it, right? So that can be another thing to consider is like, are you actually putting on the correct things, because patients may not be able to get into it. So, yes, all these are big issues here. From a more of an inpatient sort of standpoint, decreased IV access. The more you're having to access these patients, the more likely you are to have kind of, fibrous tissue starting to form over those veins. You can find it very difficult to get IV access. That can be an issue. And sometimes they're just not willing to adhere to treatment, So, for instance, I can give you the best drug in the world. It's going to extend your life by 2 years. You're 88 years old. I'm going to extend your life by 2 years by doing this, but you're going to have horrible side effects. They don't care. Like they're like whatever. I'd rather have better quality of life than necessary quantity of life. And so when you start to get more of that kind of palliative care sort of mindset, you have to consider what are the patients, what's their priorities, right? They just want to be comfortable for the rest of their life. That's fine. They may not need a whole lot of quantity of life. They want better quality of life. That's something to think about. So typically you think end of life is like having less than 6 months to live. However, that can always be variable. But when we get to that point, we're talking about palliative care. Usually when we talk about palliative care, we also talk about Yeah, hospice is another thing. And again, hospice isn't about sending someone off to the pasture to die, right? It's kind of a common misnomer. We think, okay, well, yeah, there's nothing else we can do for them. That's it. They're done. Let's go, send them off to, take them off of everything. Pull the plug, right? I always thought pulling the plug is actually a thing, but not really. Maybe if they're on a ventilator, you pull that, but those have batteries too, so yeah. Anywho, but this is one of the things you have to consider is that palliative care and hospice is more about patient comfort. It's all about increasing quality of life for the time that patient does have left. And so, certainly someone like my wife who does pain management as her specialty could tell you way more about it than I could. But basically, you kind of move from this modality of trying to have life extension more to pain relief, improving quality of life, making sure the patient is comfortable with what they have left. And then obviously, around the time of patient death, like how do you focus on the whoever the survivors are? A lot of times with these older couples, for instance, like my grandparents are married for 64 years, so I can't even imagine doing anything for 60 years, right? And, they were married that whole time. And as soon as my grandpa died, guess what? Grandma went down the hill, from a mental standpoint. Alzheimer's got way, way worse because it's like once that loved one passes away, like they don't really have a whole lot of reason left to live, So it's one of the things where they tend to decline pretty quickly. And so you have to consider that, like how are you taking care of that additional surviving caregivers or family members, things like that. So that's something to consider from more kind of a holistic sort of standpoint. And again, what do you call it when someone says, "Hey, I don't want anything else being done for me"? If I code, don't go. Yeah, DNR. So again, those are important things to consider, making sure you have kind of you have all your ducks in a row for that sort of thing from a paperwork standpoint, so that way you know exactly what they want. Because the DNR may not mean completely, hey, if I start coding, don't do anything for me. It could mean, hey, I'm okay with medications, but I don't want compressions, or I'm okay with compressions, but I don't want the X, Y, and Z, or I don't want to be intubated, or so there's different degrees of that, and it's important to be able to adhere to what their wishes are going to be there. I remember we had one lady who she had a defibrillator that was implanted. She was up in the medical ICU, and there was a question about whether she actually had a DNR that was on or not. And it was one of those things where if you have a patient who codes with an implantable defibrillator, what's going to happen when they start to code? It's going to start to go off, right? It's going to try to shock them back into having a rhythm. And so does anyone know how you turn those off? Yeah, there's a big fat magnet you put on their chest, and that will actually deactivate that sort of thing. And so I remember we were on rounds one day, and it was a question of like whether this person is actually DNR or not. And so we thought yes, she was, and they had the magnet on her chest. And so in case she did code, and they just let her go quietly. Basically, she started coding, and then someone did not have like the correct information, and so they said, okay, let's go ahead and start running. One of the docs was like, let's go ahead and start running this. So they started doing compressions. They get ready to shock the patient. And what they didn't realize is that when they shock the patient, where does that electricity like to go to? It's going to go to other metal, and so it went up through the magnets. All of a sudden, we're getting this like weird smell, and we're like, "What the heck is it?" It's actually burning flesh. It was bad. It was a bad scene. So again, make sure you know exactly what you're going to be doing for your patient, and make sure all those ducks are in a row, because you don't want to be left with that question when they start coding. You don't know what to do, right? So again, all kinds of weird stuff happens in hospitals. Stay out of hospitals if you can. Bad place to get healthy. Okay, so anyway, so talking about age-related changes that occur here. Typically, cardiac function typically is going to decline with time, just like everything else. But certainly, depending on disease states, you may find really kind of impaired left ventricular ejection fraction. You may find reduced heart rate, typically reduced function. Kidneys are going to be one of the other big places we're talking about from a drug standpoint that they're going to be taking a hit here. Typically decreased renal mass. You're going to find their GFR is going to be declining pretty steadily. And again, what are some disease states that can worsen renal decline? Diabetes and hypertension are the two big ones, right? So those are going to be the two biggest things that are going to chronically lead to worsen, ability for the kidneys to filter over time. They also have a decreased ability to maintain acid-base balance. Serum pH can be changing pretty drastically based on that. So that's another thing we're going to see. And so again, all of us are on this steady decline. So again, I'm sure most of you guys are under 30, but even us that are over 30, even ever so slightly. I'm just kidding. I'm getting older every day. It's very depressing. But yeah, we're all having declining function here. So again, we need to make sure we're really tracking these sort of things, because I can start a patient on, say, a medication. So say for instance, we're looking at their GFR. I can start them on a medication in their 50s right here, and if I don't touch the dose for the next 5 years, that renal function has still been changing on me, right? So I need to account for that and make sure I'm going back and addressing that. And I can't tell you how many patients you see coming into the ER from the nursing home where they haven't been really looking at their renal function. They haven't adjusted their dose in the past 10, 15, 20 years. And then all of a sudden they get sick, they get dehydrated, and all of a sudden their levels are sky high. And they come into us for, management of that. I've seen theophylline overdoses like that, lithium issues, so you need to look at their renal function, their change in function over time. That's really the important thing there. So other things you can find with the GI tract, typically function retains most activity. Things tend to slow down a little bit, and this is where you're going to see a lot more kind of drug interactions here, because again, a lot of these things are going to be slowing down GI peristalsis, opioids, calcium channel blockers, other GI meds, things like that can really impair absorption and kind of delay absorption in a lot of cases. But constipation is going to be a huge issue for these patients, so these are all things to consider. And so, as I mentioned, absorption typically doesn't change, but you have to consider what the dietary changes are going to be. So, for instance, they have really bad GERD symptoms and they're taking calcium carbonate all the time, they're taking their Tums, that can be binding up other medications, right? If they're taking iron because they're chronically anemic, especially with kidney patients, they need to address that. You need to make sure they're separating these things out appropriately. In some cases, you may have impaired emptying, like with a diabetic patient with gastroparesis, but again, that'll be on a more case-by-case basis. Some other changes you're going to find is that typically they're going to be losing lean body mass, and they're going to be typically having an increased amount of body fat, right? So again, on a percentage basis here, if you're looking like, say, a young adult patient versus an older adult, typically body water is going to be going down. Typically, this lean body mass is going to be going down, say, less muscle mass. What lab value do you think that might be affecting? Creatinine, right? So again, we'll have these 90-year-old grandmas that are coming in who have a creatinine of like 0.8. You're looking at them, they're like thin as a rail, and you're just like, there's no way your kidneys are actually functioning that well. If you're 90, you're going to have some degree of impairment. Your creatinine looks like it should be like a young adult, right? The thing is, they don't have enough muscle mass to really produce that creatinine. So a lot of cases, I'll do things like trying to round up their creatinine up to 1. And that way I can at least make sure I'm not overestimating their renal function too much. It helps me to mitigate that a little bit by at least rounding up to 1. So I'll do that for a lot of like older patients, 80, 90-year-olds who have a creatinine less than 1. I'll try to bump that up. But that's just to kind of cover ourselves, so that way when we're dosing, we're not dosing quite as aggressively as we would based off of that creatinine alone. But what about amputations? Remember what that does? Falsely elevate our GFR, right? Because again, creatinine is going to be lower because they don't have that muscle mass. So if you have a diabetic patient who has below the knee amputations, they lost a lot of that muscle mass. They're not producing as much creatinine, right? So you'd expect their GFR to be falsely elevated, and you again have to adjust that down to make sure you account for that. So little things like that to consider. Typically, protein binding can be affected. Mostly, you're going to find that albumin levels change based on nutritional status. So again, if I have a really poor, poor nutrition status, they're not going to be producing as much serum protein, so albumin can be affected. And for things that are highly protein bound, think things like phenytoin. If I have less albumin for the drug to bind to, that means a higher fraction of that's going to be free. And we said free drug is active, right? It can interact with the receptors. So you may find that even though the total level looks okay, you may find they're still having side effects related to the medication. It could be back to due to the albumin, right? So those are things to consider looking at. Again, drug clearance, this is one of the biggest things you have to be really prospective on. Whenever you start a new patient or start a patient on a new medication, make sure you're looking at the renal function, especially if they're antibiotics, things like even like Zantac, which a lot of people don't think Zantac is something that has to be renally adjusted, but yeah, it does. So you run into a lot of these issues here, like lithium. All kinds of different medications need to be adjusted. You have to actually look at the renal function. And so, again, we have depressed renal function with these drugs that are renally eliminated. What happens to the half-lives? Typically, they're going to go up, right? So they stick around for longer. And this is, again, why we like to avoid medications with, like, active metabolites. Because, again, they will like to stick around for longer. And so the longer these drugs are sticking around for, guess what? More likely they are to have side effects. More likely they are to have that dose stacking sort of effect that happens there, and they can have a lot of issues. And we'll talk more about drug-specific examples a little bit later. But like benzos, this is one of the big reasons why benzos are no good for older patients. Is for the most part is due to the fact that a lot of these are going to have longer half-lives, and some of it is attributable back to the renal function. Also, watch their hydration status, because again, if they get really dehydrated, that's going to affect kidney blood flow, and typically you're going to hold on to those medications as well. And that's a big reason why we saw a lot of those patients coming in from the nursing home, because again, do you think they're getting that one-to-one care 24 hours a day? No, right? They're there to make money, a lot of those places, and so they don't really pay as much attention to the patients as they probably should in some cases, especially the higher risk ones. And so they get sick, they get dehydrated, all of a sudden their levels jump up, and then they come see us for toxicity. That's more common than you might actually expect. So just remember when you're evaluating these patients, there's multiple equations that are out there. Typically for older patients, we'll use something like this MDRD equation that takes into account. We just know that it tends to work better for older patients. But for most, typical patients, when you say 50s, 60s, doing the Cockcroft-Gault equation is totally fine. But just know that at extremes of age, you're going to find that this tends to break down a little bit and may have some inaccuracies in estimating renal function. But again, remember that when we're multiplying this, like how do you affect it, or how do you modify it for females? Remember how we did that? Yeah, we multiply that by that 0.85, and why do we do that? Yeah, on average, females tend to have less muscle mass than on the same weight per weight basis. However, there are exceptions. Obviously, there are bodybuilding females out there, and there are very dainty males out there that may have some alterations there. But that is in general what they find when they did the studies originally. They found that this equation best fit that data there, right? So make sure you're using the appropriate equation. Make sure whenever you're dealing with like EMR, because again, most of you will be working with EMR very frequently on rotations in the real world. You're going to be seeing creatinine clearances that are automatically calculated. It's good to kind of ask a question like, well, how does that get figured out? What equation are they using? And that can kind of inform you like, well, is that appropriate for this patient or is it not, right? Because again, Peds is a totally different equation than we do for adults. And then, as I mentioned, this MDRDs one is really good for Geri patients. All right, so any questions from the first half? All right, so just, yes.
Sorry, real quick.
Go ahead.
Should we be memorizing formulas or just the concept?
Just the concepts. There's no, I mean, that really hasn't changed since day one, right? So I'm not going to have you memorize the formulas themselves, but the parameters that go into it, it's good to know how that affects things. So for instance, Cockcroft-Gault, I don't expect you, I couldn't do Cockcroft-Gault from memory right this second. However, knowing that, okay, well, I know serum creatinine is on the bottom. I know that is affecting the denominator. So for instance, if I have an amputation and my creatinine is going to be lower than what I would expect, I know the denominator is going to be smaller than I would expect. What does that do to my creatinine clearance? Makes it bigger, right? So I know it's falsely elevated, right? So those are little things like that. Just like C0 equals dose over VD, you don't have to memorize that specifically, but it's good to know how those are changing. So for instance, if I have a patient who I'm giving a standard dose of a drug to, but I know the level's coming back lower than I would expect, well, what's changed? Well, it's probably going to be the volume distribution. So maybe they have significant edema due to, say, CHF or something like that. It's affecting the volume distribution. Like those are kind of the concepts I want you to know. You're never on rotations or in the real world. In your cases, are going to be going out and actually having to do that calculation. We'll do it on our end, and in some cases, especially like aminoglycosides, we do that pretty frequently. But it's good to know the concepts. That way you can kind of understand why things are not happening like you would expect them to be, because some of the times the patient parameters have changed, right? To know how those have changed things. So, yep. All right. So anyway, so going to metabolism in Geri patients, typically you're going to find more drug-drug interactions than anything else, specifically with like CYP interactions being the more common ones you're going to run into. So CYP3A4 inhibition, 2C9 inhibition, things like that. You may find that, especially patients with like impaired liver blood flow, so say for instance, like they have like cirrhosis or like CHF, they may have impaired ability to get the drug to the liver to be metabolized, and that can slow things down, right? Because again, the liver can only metabolize what's actually being delivered to it, and if that's slowed down, if it's backed up, then that can slow the whole process down in general, and half-lives will get longer at that point. So question is, with these pharmacodynamic changes, are Geri patients more sensitive? Well, the receptors really haven't changed all that much. You may find that they are upregulated or downregulated depending on certain influences. However, what you're going to find is that typically it's the pharmacokinetic changes that have occurred that make them more, have changed their levels essentially, right? So instead of it being necessary that, patients are more sensitive to, say, the CNS depressant, it's going to be more the case that maybe they have a prolonged half-life of that CNS depressant and the levels have risen. So again, anyone would have more side effects if you increase their levels of the drug, right? It's just the fact they can't clear it as effectively. And that's usually what's going to be the case here. You're also going to find they're going to have less kind of homeostatic kind of reserve. So for instance, when you go from sitting to standing, your blood pressure can respond pretty well to that. As you get older, you're going to find that response gets less and less, especially when you start to add on medications, right? So again, that could be another big reason for falls. Okay, so let's look at some specific drug examples. And again, now that we've had context for a lot of this stuff, we can kind of talk about it more specifically. So again, looking at and have you guys heard of the beers list before? And I know I've mentioned it before. It's not what you get at World of Beers. What you're going to be seeing is medications to avoid typically in your Geri patients, right? A lot of them are going to go back to CNS altering drugs, right? So sedative hypnotic agents. When I say that, what do you think of? So antidepressants can have some sedative nature to them, such as TCAs and things like that. But like medications for sleep, benzodiazepines are going to be one of the big groups there. You're going to find that they tend to have increased half-lives due to either drug-drug interactions or due to impaired kidney function, impaired liver function. And what you can also find, you're going to have an increased accumulation of active metabolites. When I say active metabolite, what does that mean? Basically, the drug gets broken down, but it gets broken down into a compound that still can act as a benzo, or can act as whatever the parent drug was. And so what you find is that if you have impaired clearance of those metabolites, they stick around for longer, and the levels are going to continue rising. That's when they can end up seeing side effects associated with these. So you have to be careful for those. Typically, for these patients, we like to use medications that have no active metabolites, because that's going to give us a much more kind of predictable response. We know that whatever the level of drug is, that should be what their effect is going to be. So as long as they clear that parent drug, they're fine, right? They don't have any of these active metabolites built up. We see this a lot with things like morphine. Morphine has a couple of active metabolites. There's a morphine 3-glucuronide and morphine 6-glucuronide. The 3 actually has equal analgesic activity to the morphine parent compound. So if you have poor kidney function, guess what? That starts to build up, and you have more of the analgesia. But more importantly, what's the big side effect I worry about with opioids? Respiratory depression, right? So again, you can see someone who potentially has some pretty significant respiratory depression and die from that. So again, just be careful with that. Typically with analgesics and with opioids, and what kind of happens with a patient's response to opioids over time? They get tolerant, so that leads me to do what? I have to increase the dose to get the same response. And so you can find that you can have, 90-year-old grandmas who are thin as a rail that happen to be on doses of opioids that would kill a horse, right? Because of the fact they're so tolerant to those doses there. But you're going to find they can still be susceptible to respiratory depression. It's just that over time they will get tolerant to some of those effects there. But the active metabolites are the other big thing. So like morphine, not great. However, you can use things like fentanyl. Totally fine. You can use things like perhaps like the hydromorphone, Dilaudid, that has less active metabolites you have to be concerned with the morphine. So little things like that may guide you to choose one drug versus another. Antipsychotics and antidepressants, so these can be pretty problematic and can be another source for kind of altered mental status. With lithium, and where do we use lithium? Yeah, bipolar disorder. You have to be really, really careful, because that's the only way that lithium gets eliminated. The kidneys, right? Because remember, lithium looks a lot like salt. So if salt's being held on to, you're holding on to lithium too. So again, lots of drug interactions. If I throw an NSAID on board, and remember we said with NSAIDs, you can cause a transient decrease in renal function due to causing that afferent arteriole to close up. You can see lithium levels start to rise. And so, okay, well, the patients, is going to have these CNS manifestations. Is it because they're having dementia, or is it because their lithium levels are higher than they should be? These are questions you have to kind of ask. With antidepressants, you're going to find that typically we like to shoot for using medications that are going to be kind of more specific in their mechanism. So SSRIs are probably going to be the safest in this group of patients. Using things like TCAs can be very sedating. SNRIs could be potentially interacting with patients' hypertension. SSRIs tend to be the safest in this group. You can still use things like bupropion. You can still use things like venlafaxine, but SSRIs are going to be kind of the mainstay of therapy for these older patients, right? See. Cardiovascular agents, you got to be really careful with like postural hypotension being a big issue here. So for instance, things like, clonidine can be a really bad one for causing falls and dizziness, because again, that one's working more centrally to decrease, release of catecholamines, right? So you're more likely to see that postural hypotension with that one versus something like an ACE inhibitor tends to be a little bit safer. You don't really see as big of an effect on, vasodilation from that standpoint, even though both are effective drugs for hypertension. So certain drugs will be a little bit better than others in these cases. The other big thing you have to consider is diuretics. Probably going to end up seeing electrolyte disturbances. So for instance, if I give a bunch of Lasix, what electrolyte changes might I expect to see? Maybe hyponatremia, right? Sodium excretion. What else? What's the other big one? Potassium, right? I'm going to lose potassium. What can that do? Arrhythmias, right? So again, you want to make sure potassium is in a good range for these patients. They tend to hold on to potassium when their renal function decreases, but they can also have hypokalemia being a problem as well, right? So these are all things to think about there. And remember, imagine you have a renal patient who has a potassium of 5.5. Which antihypertensives could increase that? Potassium-sparing diuretic could, yeah, for sure. What else? ACE inhibitors. Remember, ACE inhibitors are decreasing that renin-angiotensin-aldosterone system. So by decreased aldosterone activity, you hold on to more potassium. So again, this is another case where it can find that by giving an ACE inhibitor, increased potassium, increased risk for arrhythmia. So you have to kind of take the full picture into account to see, like, okay, what's going to be best for this patient based on renal function, based on electrolytes, based on fall risk, based on all these different factors here, right? Antiarrhythmics, typically patients have a little bit worse hemodynamic reserve, especially as they get older, and they're more likely to be aggravated by electrolyte disturbances, right? So if you see hypomagnesemia, hypocalcemia, hyperkalemia, all these things can make you more likely to have an arrhythmia, especially when you have an antiarrhythmic on board. Because as we mentioned, with antiarrhythmics, what can they all cause? Arrhythmias, right? Anytime you're affecting electrolyte conductance in the heart, you have a risk for electrolyte or arrhythmia. Okay, so again, as we know that as we increase the number of drugs we have on board, we're going to increase the number of adverse drug reactions, and a lot of times patients end up starting new medications to treat the adverse reactions from other medications. And if you don't have the full history, you don't really know that that's actually the case, right? So for instance, you know, patient is, for instance, having, say, seasonal allergies, an older patient, what might you start them on for that? Like, let's try antihistamine, right? So maybe I'll give them Benadryl. Benadryl, what's the main side effects you see with that? Drowsiness. So again, you can see that being affecting your older patients, maybe more significantly than, say, younger patients. Okay, so now they're drowsy. Maybe I want to give them something for kind of chronic drowsiness. Maybe I'm going to give them something like, you know, like a modafinil or something like that to try to wake them up. That's not really what they needed in the first place. They need something that's not going to make them drowsy, right? And so if you didn't have that history of them taking Benadryl over the counter, then you wouldn't know that, right? So perhaps what could I use instead that would be less sedating? Yeah, like a second generation antihistamine. So I can use something like Allegra. I can use something like loratadine or Claritin, or I can use Zyrtec or Satir. You know, I can use something that's going to be less sedating. So these are all kind of considerations you can be making for these patients, because we know that as you start to increase the side effect or the number of drugs they're on, side effects are just much more likely, to the point where they're almost going to be absolutely unescapable. And so you're going to find that a lot of times these patients don't even understand what's really a side effect versus they just think, oh, I'm just getting older, right? So again, they get up and they get dizzy. Well, they may just think, okay, that's just getting older, versus it could actually be related to these medication side effects, right? And then always consider the OTC stuff. A lot of times you have to ask patients in kind of very specific ways. Okay, well, what do you take that you can get without a prescription? That way they kind of think, okay, well, maybe these other things I'm not even considering as drugs, and I need to start thinking about those. For instance, a big one are Goodies powders. Anyone familiar with Goodies powders or BC powders? A lot of people that don't come from Florida have never actually heard of them before. They come from like up north, they never heard of them. But what are those? Yeah, they're aspirin. They're basically powdered aspirin. These little sachet, little kind of wax paper packets, and you just put them in your drink, and you just drink it. It's powdered aspirin. Well, I mean, like in your. Well, I guess you could just. That'd be kind of grosser, but anyway. But anyway, a lot of people don't necessarily think of that as being aspirin, right? So again, they take that, say, for the headaches, but then when they have chest pain, they take their aspirin, right? And then so it's one of those things where they may not be kind of associating the two as being the same drug, and they could be getting too much aspirin effect, right? So I've seen a few overdoses that happen unintentionally because the patient was taking Goodies powders for headaches, and they're taking their daily aspirin, and then they have chest pain, and then EMS gives them aspirin. You can see how the doses are stacking up pretty quickly there, right? So from the adverse drug reaction standpoint, you know, a lot of this could be due to prescriber error. So again, not taking into account age-related changes, not looking at their renal function or their hepatic function to make sure they can still actually handle the drugs, or at least adjusting the dose or choosing a different drug altogether. Some of it could be due to patient compliance errors, so they're not taking like they should, either intentionally or unintentionally. And then a lot of it can be related back to seeing multiple providers, not everyone having the full history of what else the patient may be taking, right? And I mentioned the BC powders and Goodies example already. So when you're asking these patients about their drugs, it's good to have kind of a structured, especially when you have more time, maybe like an initial patient encounter. It's good to take a little bit extra time to get the full history of what they're going to be taking here. So, for instance, you know, when you ask, like, you know, well, what medications do you take? And they say, oh, I take, you know, metoprolol. That's one piece of information, but that's not the whole story. Tell me how you take your metoprolol, right? That way they can say, okay, well, I do this one once a day. Right, so you want them to be able to kind of teach it back to you to be able to get a full idea for what their understanding is of a medication, right? And again, that goes for anytime you're starting a new med. Say, hey, I want you to take this twice a day. have them describe back to you how they're supposed to be taking it. So I say, okay, you're taking this twice a day. When are you going to take these medications? Okay, I'll take it in the morning when I get up, and I'll take it before bed. Make sure they kind of understand what they're supposed to be doing, or whoever their caregiver is going to be, right? Ask about side effects. A lot of cases you may need to explain what side effects they should be expecting to see, because otherwise they may just think, hey, it's it's natural part of aging, or something. They may not understand it's really a side effect. So for instance, if I were to prescribe them iron to take for, say, prevention of anemia, what side effect would I want to warn them about? Yeah, black stools, right? So again, it's one of those things where they may have heard of black stools before, and they think that's an emergency sort of thing. I think it's GI bleeds versus black stools is a normal thing with iron. So that's something to say. Okay, well, here's the side effects you should be worried about. You see these. This is the ones you need to worry about. These are the ones you don't, right? That way they can understand what's going on. If they're deviating or not taking a medication, ask them why. Was it due to side effects? Was it due to cost? Is it due to, there's ways you can get around that potentially based on the answer there. Medications not on their list. Are they using non-prescription drugs? Another big thing to ask about. Ask about homeopathic drugs, herbal medications, vitamins. All those could be potential interactions there. So for instance, if they are, say, they have depression, what herbal supplement might they be on to treat that? Yeah, it might be on St. John's wort, and St. John's wort has huge ramifications from a CYP drug interaction. It actually induces 3A4, right? They got huge implications. Or for instance, if they're having trouble sleeping, what herbal supplements might they take? Melatonin, valerian root, and different things like that that could be influencing, say, some of the side effects they're having from other sedating meds, right? Ask about drugs that belong to other family members. We see some issues where older people, they like to take each other's medications. They're like, oh yeah, I had a UTI a couple of weeks back. Here, you can take the extra, Cufflex I have left over, or the Bactrim I have left over. So you can sometimes see issues with that. We'll even have some patients who are coming from different countries that will be kind of bringing some home remedies with them and things like that. And so you can actually see some toxicity associated with that one. Had one kid that had like lead poisoning related to a home medication that was being brought over by grandma from the old country. I don't know what that country was, but apparently they have lead-based medicines there. But anywho, so you can see some issues with that. Ask about, are you getting anything online? Are you getting it from different countries? Because again, the cost can be a big factor here. So if they're trying to order their medications from Canada, certainly I'm sure Canada has some really good medications, but depending on where they're ordering it from, can you believe everything you read on the internet? Because apparently there are singles in my area that want to talk to me, like, I gotta believe it. No, that's not the case, right? So again, you have to be careful. Make sure they're using kind of reputable websites. There are some certainly nefarious places out there that will be less than reputable. I'll say that. Ask about, are there any medications that you're still taking that are no longer being prescribed to you? Again, that may be harder to discern if they don't really understand. And then when's the last time you check expiration dates on stuff? Again, when you get a pill bottle from the pharmacy, what's the expiration date usually going to be? Yeah, 1 year from when the actual prescription was written. Doesn't mean those drugs are actually bad at that point. And again, typically expiration dates are kind of bogus. But again, if they're taking something from the 80s, maybe a little too long, right? So again, check the expiration dates. Certainly, like herbals and vitamins, like that one, it's hard to say necessarily, how good the expiration dating is on those products. They're not as well regulated as you will see like with FDA-approved products. But certainly things like nitroglycerin. Really important to make sure you're not taking that beyond when you're supposed to. Really, it's like 90 days after you open the little tablet container, because after that, the drug is very volatile and will start to dissipate after time. So it's one of those ones we want them to get them to actually replace it. Let's see, if you're not taking medications independently, who's helping you? Potentially that can be useful information to have. Are they using any kind of dosage system? And when I say that, what do you think that means? Yeah, pill boxes or any kind of pill reminders. I mean, there's apps that are out there. There's all kinds of different methods for patients to help kind of remind them, because that's important. Because otherwise, if they don't have that signal to take their medications, they'll forget. They may take things twice when they were not supposed to. We got tons of phone calls at the Poison Center for patients accidentally doubled up on their medications just because they forgot they took a dose to begin with. And then for specialty dosage forms, ask about how they're actually utilizing it. So like eye drops, ask them to demonstrate the technique to you, because maybe they're actually not even applying it directly and they're not even hitting the eye when they're using their eye drops. Or if they have arthritis and they can't use their inhalers appropriately, maybe you need to consider using a different sort of dosage form there. And then, yeah, and ask questions like, well, if you forget to take a med, like, what do you do to respond to that? Do they just skip it? Do they take a double dose? Because that could be appropriate for some meds and inappropriate for others, right? So these are all kind of questions you want to ask, especially like on the initial encounter. We have a little bit of extra time to talk to them and get a full history there. Okay, here's just some examples of pill minders. These can be kind of problematic from a poisoning standpoint when like kids go to grandma's house, because again they'll just say like, well, I don't know how much that they got into everything. I just see all the doors are open and there's stuff that are kind of spread on the floors. And that can be kind of tough, but very good for elderly patients to help remind them when they're supposed to take things. So, again, look at different obstacles to compliance for these patients. Yeah, it might be nice to, prescribe them the hot new NSAID that's out there, or hot new whatever medication that, the drug company just bought you lunch for, because it's the best drug since sliced bread. There's probably a lot of generic alternatives that are available too, right? So again, try to make sure you're being cost conscious for these patients. If it's on the, familiarize yourself with like the public's, cheaper free drug list. Look at the Walmart list, because again, patients are a lot of these older patients are on very fixed income, and they may not have a lot of money set aside just for medications. You want to make sure that, because if they can't afford it, they're not going to get it regardless, right? It could be the best drug in the world, but they may not be able to get it. And just look at things like mixed dosing intervals. Like, try to keep it simple for the patients, right? So if you can do one-time daily stuff or twice daily, just keep it simple like that. Make sure they're not taking this medication at this time of day, and then I take this medication then, and this medication. Like, keep it all as simple as you can. And then you look at things like, patient, can they physically take the drug? If it's an inhaler, what's a one way you can get around? Some of these older patients have kind of issues of coordination with inhalers. How can you get around that? Yeah, so using a spacer valve holding chamber can be useful, so that way the patient can kind of breathe in the drug independently when they actually squirted the medication. So little things like that to try to make sure they're taking these things accurately. Okay, so any questions on Jerry stuff? So just real brief, I know you guys are experts at prescription writing now, but just to make sure we are covering all the kind of legal requirements and things like that, and there might be a few questions on the test regarding this. Again, who can prescribe? Lots of people, like physicians, PAs, nurse practitioners. Can you guys prescribe controlled substances? Yes. Well, what's the caveat there? We have to apply for it, right? You have to go through like special training afterwards, and you have to pay for it. Yeah. But it depends on where you're working. If you're in the hospital, usually you're writing under the DEA for the hospital, things like that. So it'll be different where you're at. But yes, now you guys can write for controlled substances. But veterinarians, optometrists, lots of different people can prescribe there, right? So just remember, when you're dealing with state versus federal laws, you typically want to go with whichever is stricter, right? In general, you can't really go wrong if you follow whichever one is stricter. Now, there may be some odd exceptions. So, for instance, medical marijuana, right? Federally, still a Schedule I substance. Federally, still a crime to possess or to use. However, a lot of states are saying, well, no one's going to come after us. Let's just go ahead and do it anyway. And so they're passing state laws that will allow that. So again, Florida, we are one of those medical marijuana states now, right? So again, make sure, in general though, follow whichever is going to be the stricter law. And if it's not addressed in state law, go with the federal law. Okay, so our requirements, and you guys have been practicing this all, and one of the things with the prescription assignments I'm giving you is that, is my way of writing prescriptions the way I tell you to write it the only way to do it? No, like I'm trying to tell you from the absolute letter of the law, this is everything you need to have to make sure you cannot get in trouble. When you go out there and practice, you're going to see lots of different ways to do it, and that's fine to follow that. You can do your own thing when you get out there. But for our purposes here, I just want to make sure everyone's consistent. You at least know what the kind of the top level is, and then if there's some ways to shave off time or ways to make it a little bit more easy later on, you can do those things, right? So that's why we kind of try to make sure you guys get all the practice handwriting it, because most of the time you're never going to handwrite it ever in the first place. So anyway. But make sure that it's very legible. Make sure you have the name of the practitioner. These are all things that are being set out by the law to say this is what you need to have on the prescription for it to be valid, right? Notice you don't need things like the brand name of the drug. As long as you have the generic, you're totally fine from that standpoint. Typically, you're not allowed to pre-sign prescriptions, so you don't want to have anyone that's just rubber stamping a bunch of empty prescriptions because someone stole something. They can go and fill in whatever they want. That's no good, so you can't do that. And typically, they can be called in. They can be communicated. Typically, when they get to the pharmacy, though, you're going to find that the pharmacist, a pharmacist or a pharmacy intern, which would be a pharmacy student who has an intern license, has to be the one to dictate that from the phone written down. So you don't have a technician who's doing that, because if there's a transcription error, they write down the wrong drug or the wrong dose or something like that, they need to make sure that it's a pharmacist or someone who's going to be a pharmacist actually does that. But and then once it's called in, then we'll actually reduce it to writing, and that will be our record there. And again, all prescriptions are only good for 1 year, but we'll talk about controlled substances, how those are a little bit different in a minute. Okay, so you can put multiple non-controlled scripts on the same prescription. I have you guys separate it out just so that way you kind of get practice and it's more legible for me, so you're not trying to squeeze in a bunch of stuff all at once. But typically you want to keep controlled substances separate from everything else, and especially C2s have to be by themselves. So you only have like one C2 script on each prescription there because they are actually filed separately from all the other ones. Because again, if the FDA or the DEA came in and said we want to see all these scripts, we have to be able to retrieve those very readily, and so that's why we have to keep them separate. So, example, you've already done a bunch of these, but you kind of know essentially what the whole process is here for writing these. Again, just some other examples. A lot of times you're going to find that these are kind of pre-done, so that way you can just like check off your name if the name's present on there. And a lot of the information is already kind of done for you, which is nice. So that way you don't have to remember everything to include on that like you do for mine. And don't write like this. No good. Yeah, most of you guys have pretty good handwriting. I don't think I've seen anyone who's particularly egregious. One of my other students over at Nova is got the worst handwriting ever. My wife was looking at it. She's like, oh gosh. And I was like, no, he's the worst. It gets all better from here. But you guys do look pretty fine already, so I'm not too worried about your handwriting, which is good. You don't want to see it. Trust me. It's an affront to mankind. No, just kidding. Anyway, so again, other things to consider for controlled substances, you need to have the address of the patient on there because again, the identification for the patient is really important. Or if it's an animal, and when do you think animals would need controlled substances? They're not doing it at home; they're doing it in the office. So most often you're going to find for seizures is one of the most common ones you run into. So phenobarb for like dogs and things like that and cats is the most common thing that I run into, at least the short time that I was doing retail stuff. And so again, you'd have to have like the owner of the animal because they're the ones that are going to be signing for it when they come in. But generally you should be saying what the species is as well. So if it's a cat or a dog or whatever, you want to include that on that information there as well. Yes, ma'am.
So how different is it if it's for a dog?
As far as what?
The phenobarbital, for example.
The dose or?
Well, the drug, it's the same.
I mean, it's the same drug, the same chemical. We just may give it as, because, a lot of times, like, if you're writing, like, Keflex for a dog or something, I remember the biggest dose of Keflex I ever saw was, like, it's for someone named, I'm trying to remember what the dog's name was. It was something like He-Man or, some weird, like, He-Man Johnson or something like that. It was just, like, and this is this massive dose of Keflex. It was, like, enough to kill somebody. I was just like, what the heck is up with this? And they're like, oh, it's a dog. And so it was like a Burmese mountain dog or something with like a skin infection we were treating. Maybe by including that information is useful. It's the same chemical, right? And so for those are capsules that we were just breaking open and putting it like into the food or mixing it into something or other. But it's the same chemical entity. It just depends on how they're going to take it. So might do like phenobarb elixir or something like that for potentially for a dog. If it's easier to do like an oral syringe, just depends. But and again, with as far as from the DEA standpoint, you need to have all the information for the prescriber. So have like the address, the full name. We need the DEA number at the very minimum. Typically, you should have some sort of identification as far as like a license goes. So either like an MPI number, your medical license number. But DEAs have to be there for the controlled substances. If that's not there, we're not going to be able to run that. And then you need to make sure you have the written and the numerical amount. So for instance, when you mentioned we did the high-set prescription, it's good for the quantity. Make sure you have that written out. So that way the patient can't come in and try to write in like an extra 0 after a 10 or something like that, right? That's just in order to try to prevent any kind of modification by the patient. As I mentioned, Schedule II substances, they can be typed, but they have to be on paper. You cannot communicate that via fax or over the phone. Like that has to be brought in by the patient on the actual script itself. And just know there's no refills on a C2. You can write up to a 90-day supply, but there's no refills available on those. On the other hand, though, for like a C3 through a 5, how many refills can we do? You can do up to 5, so a total of 6 months worth of drug, because those scripts are only good for 6 months at that point, right? And they have to be hand signed by the provider, so there's no stamping, no anything like that. Certainly for other scripts, there's like you can have like electronic signatures that come out. So for instance, like if you're writing a script at the ER at Nemours, if you wrote for like amoxicillin, it would come out. You don't have to sign anything; it's already electronically signed by you when you typed it in. But for the controlled substances, they'll show up and they will have a spot for you to actually have to hand write the signature. Otherwise, it's not considered valid. Mentioned 3 through 5s are going to be 6 months, and those actually can be communicated in via the phone, but C2s have to be brought in on the paper. And that paper typically is going to be on counterfeit proof paper, and these actually have to be gotten through very specific vendors because they keep track of who all is getting these counterfeit proof papers because they don't want people to be able to make their own counterfeit proof paper and use that for their own kind of nefarious purposes. So it's very specific. They're all numbered and whatnot. And notice here when you photocopy them, they will have that big void sign, or they'll have something that will indicate that this has been photocopied at some point to show that it's not valid anymore. So that's another big thing they'll do there. So those C2s have to be written on counterfeit proof paper. If not, then they're not valid, right? So we need to have that on there. And again, hand signed is very specific. Just remember, watch out for unapproved abbreviations. Like we get in trouble for this, like from the Joint Commission. You guys familiar with Joint Commission? Who are they?
They credit the hospital.
They accredit the hospital, right? So if you get the Joint Commission on your tail and you lose your accreditation, you don't get paid by Medicare or Medicaid, like you lose a lot of money. So it's very important for people to make sure they get their TJC accreditations. And so anytime, it was always funny, like my mom, she was the CNO for a small like community hospital in Putnam County for a long time, and you could always tell when the Joint Commission time was coming around because she was like, always at work for like 12 hours a day and she was stressed out. And my dad was just like, just don't even bother your mom. Just for this month, just leave her alone. Same thing happens when I was at Nemours and I was like in more of a management position when Joint Commission came around. Just don't bother me. Like just leave me alone because there's a lot of stuff at stake here. But again, unapproved abbreviations are huge for them. They don't want to see anything like QD. The CQD, like you get dinged for that, right? So that's why make sure you guys have that approved list of abbreviations to not use, so that way everything is consistent there, right? So again, you're always better off if you can write things out fully. However, abbreviations are okay as long as they're not on these kind of unapproved abbreviations. They could be misread, right? So for instance, you're not writing U, but writing units. Not to write international units, but just units is fine, right? And that way it's very clear, because if I wrote 10U, that could look like 100, potentially, especially if it was handwritten. So that's why we avoid those kind of abbreviations. So again, make sure you're including the strength and dosage forms. That's why it's good when you're including, like under scripts, especially the liquids, say what the concentration is, because there could be multiple concentrations. Amoxicillin comes in a bunch of different strengths, and so if you write for the wrong one or you don't specify, that's going to be called back to you when things don't make sense. Right. It mentioned using mLs only, which you guys are pretty good about so far, and then avoid trailing zeros, right? So don't use 5.0, just write 5. If you write 5.0, that can be misread as 50, and I've read several scripts, both schools, where they'll write 5.0 or something like that, and it can easily be misread as 50, right? So, and then always use leading zeros. You want to use, and actually I miswrote this one, but I didn't. But you should write 0.1. That makes it very specific. 0.1 can be misread as 1, so you don't want to do that. So always use a leading zero in those cases. So again, include the quantity. It should make sense based on what you're actually prescribing. So if I write it for a daily medication, it should probably be quantity 30, right? And then typically at the pharmacies, if you want us to give the brand name, you have to write DAW, which means dispense as written. Very rarely does it ever really matter. Generics work just as well as brand names. If you remember back to our pharmacodynamics class, the intro to pharm class, that they have to prove bioequivalence. They have to show that the generics are just as good as the brands. Otherwise, they can't market themselves as a generic. So again, this is more of a cost issue for the patient as well. It's usually cheaper to get the generics. So if you want the brand name, just write DAW and they'll get the brand. Okay, and again, including indications is super useful. Again, not required by law, but it's very helpful because it helps to show the patient what they're taking it for, and also so that the pharmacist can verify, okay, this makes sense based on the indication, right? Okay, and then how to keep pesky pharmacists from bothering you when you're out there working. Make sure you're reviewing the patient's med profile before you're writing stuff, so that way you're not having any antagonistic combinations. So that way I'm not writing for something that's going to increase blood pressure when they're on a bunch of antihypertensives. There's no duplicate therapies. Make sure we're avoiding allergy issues that are going to pop up there, and just make sure things are really legible if you can. And then obviously right within your scope of practice, if you work at a derm office and you write for ADHD meds, you're going to get a phone call, or at least the patient's going to get turned away because I'm not going to fill that, right? If you're a podiatrist, don't be writing for weight loss meds, things like that. Those are things that are kind of outside the scope, and so that would not be appropriate to write for, right? Okay, so any questions on any of that? All right, any questions on the other stuff we covered? So what we had, OB-GYN stuff, and we had, what was the other section? Yeah, diabetes. Yeah, diabetes is a big thing. So any questions on any of that? Yes, sir.
You posted a PDF file on a bunch of oral contraceptives.
Just memorize that whole list. Just kidding. No, the main point there is just to show you different varieties that are available. Again, when you're working, if you prescribe that with any regularity, you'll have a couple that are kind of your go-to drugs, But the main point was to show that, hey, the main components that are changing here are going to be the progestin. They're going to be included, right? And go back to that table that we had, you'll find that some of them are going to have high androgen activity, some of them have no androgen activity. That's going to be important for side effects, right? Based on, some of them are going to have estrogen activity, and that can affect bleeding and things like that. But also the fact that you can have, triphasic, biphasic, monophasic, there's lots of different varieties that are out there, and to kind of get you acquainted with, just the multitude that are available. Any other questions? So again, with like the diabetes stuff, like be aware of like, okay, how are the different insulins acting? Which ones are my fast acting? Which are my long acting? Which ones are kind of intermediate? Know what situations those would be appropriate for. So for instance, if I have like a type 2 diabetic patient that I'm starting on a new insulin regimen because he wasn't being well controlled on, say, oral medications, what do you think I'd want to start him on? Short acting, long acting? Probably long acting, right? Because again, you want to try to minimize the number of injections they're having to get. So I'd probably start on a long acting, say once a day or something, right? That would be appropriate. What would be an example of a long acting insulin? Humalog is gonna be fat. Remember, think Humalog, think logarithmic fast, right? Like Lantus, so insulin, glargine, Detamir, Levemir, insulin Degludec, Tresiba. Those are the long-acting ones. Those are good for daily administration, right? Humulin is just normal, regular insulin. So if you like Humulin R, that's regular insulin. That's going to be fast, but not as fast as some of the other rapid-acting ones, right? So things like that. No common side effects for all those diabetes meds, because again, you want to be able to pick appropriate meds based on comorbid conditions, based on potential side effects, things like that. The OB-GYN stuff, just be kind of aware of, how we're using those medications. If, for instance, like, a patient has an intact uterus, what do I need to make sure I'm including along with estrogen? Yeah, right. Versus if it's postmenopausal woman, she's had a hysterectomy, something like that, you can get away with just estrogen by itself. How we can mitigate systemic side effects by administering things that are going to be more locally acting or more topical. What else? There will be some drug dosing ones on there, but again, most of them you can do with scratch paper in your head. Will not be difficult. It'll be pretty round numbers you're dealing with, so it will not be too burdensome. Any other questions or anything? Well, congratulations, you made it through pharm. All 3 semesters, fantastic. Good job. I will say, if you guys have questions, like I don't stop being your teacher just because I don't have you in class anymore. So if you have questions, if you see something weird or anything like that, you have my email. You can always get a hold of me somehow. So I'm always happy to talk to students after the fact. But yeah, other than that, I think it's been a pretty good year. You guys learned hopefully some stuff. Again, the whole point was not to memorize everything in class, but to have the wherewithal to know when to look things up, know when to go to the experts, know when to ask other people, because again, you're not working in a silo, you're working within a team. So go talk to the pharmacist if you see something you don't understand or you don't know, because if you sit there and act like you know everything and don't ask anyone, guess what? You're only likely to make mistakes. That's no good. So be able to admit when you don't know something and go talk to the experts, right? Know your drug references, like, figure out what the references at that hospital, wherever you're working at, figure out, you get comfortable with using it so you can look up information quickly, things like that. So that way you can be like, well, I know I've heard of that before. I remember Dr. Wood talking about that, but let me at least look it up so I get the full info on it, right? Those are the things to really make sure you get comfortable with. When you're actually working, whenever you decide to land in, more or less permanently, like you'll get like a set of drugs that you just use every single day, like 24 drugs that you're like, I know these back and forth. You'll probably know them better than I will, right? Just because you use them all the time. But until then, like, just look stuff up. That's the biggest thing I can recommend to you guys in the meantime. And make lots of mistakes on rotations, because that's the time where you have no liability really, no responsibility. So screw up all you want on rotations. That's a good time to do it. When you have a license, that's where you want to be a little bit more confident in what you're doing and make sure you're not going to screw anything up too bad. But yeah, try to take opportunities to learn everything you can on rotations, because this is the one time where, again, you can be ignorant as you want to be, because you're there to learn, right? So that's a good time to learn all you can. So any questions or anything I can help you guys with? So prescription assignment will be due next week. I won't be here for the test, but good luck on that. And then I'll send an announcement out with any high misses or anything like that after the fact. So. All right, it's been a fun year, and I'll see you guys around. Yeah, thank you.